Thank you. So on to another topic. I'd like to thank the moderators again for allowing us to present our work examining whether we should be doing routine esophageal manometry in all of our patients. Again, our disclosure were exactly the same as the previous presentation. So as we've seen in many of the sessions over the past few days, the routine preoperative evaluation for foregut procedures, especially anti-reflux operations, includes the videoesophagram and esophageal manometry. These studies are important for determination of esophageal motility, but there's no specific guidelines on how to use these results to inform clinical decision-making. Most would prescribe to the idea that patients with poor motility should probably get a partial wrap, whereas patients with normal motility can be candidates for a full circumferential wrap, including a Nissen fundoplication or a Lynx device. However, obtaining reliable esophageal manometry is not always easy, since it requires specialized equipment and training for individuals who are performing and interpreting this exam. This led us to ask ourselves whether or not this test is always required for every single patient. Based on some of our anecdotal experience, we hypothesized that if a patient had a normal videoesophagram, that manometry did not reveal any clinically significant esophageal dysfunction. We performed a retrospective review of patients who underwent both videoesophagram and high-resolution manometry at our institution. Most of these studies were performed as part of a routine pre-surgical evaluation for a foregut procedure. An important aspect of our preoperative evaluation is a very comprehensive, structured, and protocolized videoesophagram that's done by a protocol developed at our institution. As you can see here, this table illustrates the various aspects of that study with multiple sequences in multiple positions to fully evaluate swallowing. Specifically for our study, we focused on aspects of that protocol that can be used to assess esophageal motility. First, in the prone position, patients have 5 separate 10 cc swallows of contrast separated by 15 seconds. Patients are encouraged to swallow the entire contrast bolus at the same time. Also included were 2 swallows of barium-coated meat or marshmallows to assess solid swallows. Stasis was defined as a residual contrast bolus present in the esophagus after the initial peristaltic wave had passed, and a normal videoesophagram was defined as stasis on less than 3 of the 5 liquid swallows. High-resolution manometry was performed according to our protocol, and we looked at specifically 3 measures of esophageal motility to categorize patients into normal versus abnormal function. Those were a distal contractile integral less than 450, mean wave amplitude less than 30 millimeters of mercury, and percent of peristaltic swallows less than or equal to 50%. The Chicago classification was used to diagnose motility disorders. There were 418 patients, 182 males and 236 females, with a median age of 62 years. 231 patients met criteria to have a normal videoesophagram, whereas 187 patients did not. When looking at the amount of patients in each group with abnormal findings in each of those 3 designated measures, there were significantly more patients in the abnormal videoesophagram group. 8.2 versus 17.7%, 1.3 versus 7%, and 5.2 versus 24.6%. Since it's rare to make a clinical decision based on one isolated measure, we looked at specifically composite measures of these findings in order to see how many patients had more than one abnormal finding. When looking at patients that had an abnormal distal contractile integral and percent of peristaltic swallows, there were only 2 patients that had both abnormal values. This corresponded to 0.9% of this entire, when to look at these composite measures, we looked at patients that had a normal videoesophagram to see who had multiple abnormal values. And so 2 out of the 231 patients in the normal videoesophagram group had both abnormal values. When looking at distal contractile integral and mean wave amplitude, there was only 1 patient in the normal videoesophagram group, or 0.4%, that had both an abnormal DCI and an abnormal mean wave amplitude. Last, there were no patients that had both abnormal percent of peristaltic swallows and an abnormal mean wave amplitude. When looking at manometric diagnoses, there were more patients in the abnormal videoesophagram group with manometrically diagnosed disorders. In yellow, I have highlighted disorders that we have determined as a group to be clinically significant, as in it could affect your overall surgical plan or choice of anti-reflux procedure. Based on these findings, our ultimate goal then became to assess the ability of a normal videoesophagram to reliably exclude the presence of clinically significant motility disorders. First, we compared the rate of clinically significant disorders between normal and abnormal videoesophagram and found those two to be significantly different. Second, we assessed the ability of the videoesophagram to accurately categorize these patients as having a potential motility disorder present or not. To do that, we compared the results of the videoesophagram against what would be considered the gold standard, which would be a motility disorder diagnosed on manometry. And the findings you can see on that table. First, if a patient had a normal videoesophagram, 230 out of 231 of those patients did not have a motility disorder. This corresponds to a negative predictive value of 99.6%. Second, if a motility disorder was present, then the videoesophagram was abnormal in 27 of 28 of these patients, corresponding to a sensitivity of 96.4%. Due to the high number of patients that had no motility disorder, the positive predictive value and the specificity were both relatively low. So in conclusion, when a structured protocolized videoesophagram has normal results, no patients in our study had achalasia or absent contractility. It was rare to have an abnormal motility finding, and it was extremely rare to have more than one abnormal motility finding. Therefore, we have concluded that routine manometry is not indicated in all patients and should be reserved for patients with abnormal videoesophagram. Thank you.